Hello, everybody. I'm Dr. Steve Carstensen, Chief Dental Editor of Dental Sleep Practice Magazine, a MedMark publication. Welcome to a presentation and Q&A with Dr. Jonathan Ford. In our webinar today, we'll be discussing the impact of mandibular advancement design choices in mitigating potential side effects if properly implemented. Before we get started, I wanted to invite viewers to use the Q&A to ask any questions. We're going to answer them at the end of the presentation as time permits. I'd like to introduce our speaker now. Dr. Jonathan Ford was born and raised in Huntington Beach, California. After graduating from Marina High School, he attended the University of Pennsylvania School of Dental Medicine. Quite a different climate there, Dr. Ford, from Huntington.
Just a bit.
Where he earned a BA and graduated Cum Laude honors. Also diplomated with the American Board of Dental Sleep Medicine. He's passionate about educating the community and other doctors about dental health. He's a resident faculty at a dental continuing education facility called CDOCS, that's been around a long time, where he teaches other dentists how to implement dental sleep medicine into their practices. He served as president of the Huntington Beach Kiwanis and volunteers his time doing dental clinics at orphanages in Les Ceyes, Haiti. Along with continuing his postgraduate education and advancing his understanding of dentistry, also an active member of the ADA, California Dental Association, and Orange County Dental Society. Outside of dentistry, he's an avid sports fan, enjoys being outdoors, and has a wife, Nadia, and two children, Emma and Zane. So thanks for joining us, Dr. Ford. Now I'm going to turn the webinar over to you to learn more about mitigating side effects.
Thanks, Dr. Carstensen. Thank you for all attending the webinar this evening, for taking time away from your families to learn a little bit more on how I think each individual appliance on the market has an impact on the teeth. And I was joking around when we came up with this title for this lecture. We wanted to get a little nerdy into the Star Wars and think about may the force be with you, because you're going to hear me talk a lot about bioengineerings and physics tonight during this lecture. You're going to hear me use force vectors and things that I never thought I'd talk about again outside of physics and undergrad, and maybe a few terms that were brought up in my dental materials lectures at Penn Dental. But we're going to talk about that tonight because what I thought was happening with these appliances is actually it isn't happening. When I was just getting into the dental sleep world, I thought to myself, we want to splint every single tooth and almost create like a retainer with a device and then force that mandible forward. We're going to put a little bit of force on the maxilla and stabilize these teeth as much as possible. And if you splinted all of these teeth together, they would hopefully stay there, not have any open contacts, and we mitigate some of the side effects that we know exist in the dental sleep world. It's the stuff that we're used to, and it's the side effects that we're okay with. We'd rather have maybe a tooth movement here or there rather than having some of the systemic impacts that patients with untreated sleep apnea have, heart attacks, strokes, and all the things that we're aware of. But we're going to go into and have a paradigm shift or have a little different of a vantage point and show you what happens with these appliances and how it affects overbite, overjet, and maybe you're going to see some things that are new, and it might take you some time to think about how these appliances actually create some of these movements. And I remember sitting on an airplane after reading some of the research papers that I'm going to quote tonight and just kind of looking at that. And it took me 20, 30, 40 minutes to finally have it click in my head that maybe some of these appliances actually do the exact opposite. Maybe they're increasing overjet and overbite. And is that maybe something we're okay with when we talk about this overjet and overbite discussion? So that's kind of a quick summary of tonight, but I always like to start all of my lectures, especially my dental sleep lectures, with this quick video. It's follow the directions on the screen. It's pretty simple, pretty straightforward. I'll be quiet here so all of you can concentrate. And if we're all paying attention, hopefully we were, the answer is 13. But I'd like to rewind this video real quick and show you the moonwalking bear that most of you probably missed because we're so focused in on seeing the team in white make those 13 passes. So there you go. Bear comes moonwalking across the screen, and we saw the same video twice, but now we see something completely different. And it's easy to miss something you're not looking for. And I think this epitomizes the current relationship with dentists in general who don't have any sleep training and those that do, because we can look at the nuances of the tongue. We can look at the soft palate, the Mallampati scores, and pick up these patients that have undiagnosed sleep apnea and pick it up a lot quicker. But I also like to just point out that when you start educating yourself, you start to see things completely differently. And when you start seeing things completely differently, you then can treat or diagnose and treat patients differently. So hopefully tonight, I give you a little bit of an education. And one of my mantras is the eyes don't see what the mind doesn't know. I'm going to say it again because I think it's really important, is the eyes don't see what the mind doesn't know. Hopefully your mind picks up on a few nuggets. You start to see things differently, and you can take that to your practices tomorrow or next week and start treating these patients a little bit differently and seeing the appliances and the effects and the force vectors a little bit differently on how we select appliances and how do we mitigate side effects. So the learning objectives for tonight is how does appliance design and also the material that it's made out of affect the jaw and the teeth? How do we then, and then what are the possible side effects? And how does a clinician prioritize the side effects? How do we create like this flow chart or hierarchy in our heads on what side effects we're okay with, or how do we minimize the bad side effects? And how do we maximize the pros to it? But if we are going to have to put forces on certain teeth, how do we prioritize and make those decisions? So that's the goal for tonight. So let's take a look here. And like I said in the very beginning, I started with that every single mandibular advancement device, I wanted to wrap everything. I wanted that retainer or that appliance to be retentive. I wanted it to touch every single tooth. And what I realized and kind of had to have a paradigm shift away from this is that every time that appliance is touching a tooth, it's going to create and implement and put a force on that particular tooth. And it's not only going to put a force on that tooth, it's going to put a force on the TMJ joint and put a force on those muscles. And the goal of this is, yes, we want these patients to breathe better, but how do we eliminate the side effects, the things that the medical world, they also try to mitigate it as well, is how do we mitigate all that, but also achieve the best possible result for the patient? And whatever force we put on the mandible, we're going to have an equal and opposite force put on the opposing arch, which is the maxilla, put on the opposing teeth that are involved that are in the maxilla. So we have this, you're going to hear me use the terms push and pull a lot, and then force vectors a lot as well. So it's not only the teeth, but it's how do the forces translate through the teeth, through the contact points as well. And also when we don't have an intimate contact point with the appliance from the tooth, maybe that's a good thing in certain cases. Maybe we have these fragile mandibular incisors that we can relieve, or maybe when we look at the details of a Panther device, when they don't have the full wraps or the bands completely touching all the teeth, there's a reason for all those decisions that they make. So hopefully you're going to see that we're going to have a little bit of a paradigm shift when we go through this tonight. So I want you to focus here on the people pushing against the wall. And I want you to think of how hard the first person is pushing against the wall and how much force they are generating. And then all the subsequent forces with all those people lined up, all 5 of those people lined up, or 4 people lined up behind the first one for a total of 5. no matter how hard that fifth person pushes, there's not going to be this opposite or equal push against them against the wall. No matter how hard you push, you're not going to get that equal and opposite push compared to that first person. The reason I put this up here is think of your mandibular advancement device and think of where the appliance interlocks or joins or attaches. That attachment point between the bands or how it interlocks the mandibular arch with the maxillary arch with the mandibular arch, how they interact and where they interact. That person where that interaction is, that interlocking, that engagement, that's where the most force is going to be, and it's slowly going to be dissipated throughout the appliance. There's still going to be some force, but not as much force where that initial interlocking connection is. So for like a tap appliance, it's going to be that maxillary and mandibular anteriors. For a bilateral push, maybe it's going to be in a different location, maybe the maxillary posterior teeth and the mandibular canine teeth. With a pull device, maybe it depends on where this attachment point or this connection point is between the two devices. Maybe that's where the most force is going to be. So when I think about that, then I kind of put the teeth or one tooth in there. And it's these examples of where are these forces going and which way are they directing these teeth. So an example is if we have a terminal molar and we're pushing that tooth in a way where there's nothing behind it, that force is going to move that particular tooth in that particular direction. Now, the appliance can be designed in a way to try to minimize that, but there's still going to be some force there. Let's think about when we add another tooth. Now, if we're pushing those teeth, but we're pushing that tooth into other adjacent teeth and into contact points, are we going to get as much movement potentially with that tooth? And the answer is probably not, because all of that energy or all that force is then directed or absorbed by other teeth. What if, because these aren't perfectly the force vectors that we're talking about for mandibular advancement devices, they're not all in line with the adjacent teeth perfectly. If we're putting more force on the mandibular anterior teeth and it's a force out or to labialize those teeth, there's no really teeth holding that back. And if you put force on teeth, we know from orthodontics, when you put a wire on a tooth and put force on it, that tooth is going to start moving. So we can try to stabilize that as much as we can, but we also need to look at not only the total strength of the force vector that we're putting on, but also the direction of the force vector. And we're trying to put those force vectors in the directions so the other teeth absorb some of that pressure. And I know it's probably not what all of you guys were expecting getting a bioengineering lecture or a physics lecture tonight. So what you may need to kind of sit down with this and review it and let it soak in before you kind of see the impact that each of these appliances can have on these teeth and how it's really trying to mitigate these forces. If we're going to have to put forces on teeth, let's put them on the strong teeth in line with so the teeth can absorb it. And if we're going to have to put forces on weak teeth, how do we minimize that? And it's that hierarchy that we have to think about with appliance design. So I think I know there's hundreds and hundreds of appliances on the market right now. And I think we can fit each of those appliances into each of these four categories. Kind of the midline push-pull. There's the bilateral push, which I think the very common one that most people realize is the Herp style appliance. There's the bilateral interlocking or fastened appliance. Another terminology for this is just the dorsal fin. And then there's the bilateral pull or the bilateral kind of traction device. And I want you to start thinking here is each of these appliances, they're going to put forces on teeth and then equal and opposite forces against the opposite arch. So if the mandibular arch is getting pushed forward, the mandibular arch is getting pushed forward, the maxillary arch could potentially getting pushed backwards. But where in the arch and where is this connection point and what where the connection point is, what force is being put on those teeth, and where can the force be absorbed by potentially adjacent teeth. So when I teach this, I always want to think of and start prioritizing what are our strongest teeth, what are the teeth that are the hardest to move, and then what are the teeth that are the weakest to move. And I go back to dental school days when we talked about like where we put a bridge and how many abutment teeth we need, and it looked at root length or the surface area of the root and how strong, essentially how more surface area of a tooth, technically the stronger that tooth is or the harder that tooth is going to move. So I think the first two, if you want to argue with me, I think it's 1A, 1B, maxillary canines, mandibular canines, maybe mandibular canines first or maxillary canines second. Those are typically seen as kind of stronger teeth in the mouth. Then I kind of start to think of mandibular molars. And why did I put mandibular molars first versus maxillary molars? Is I am still a restorative dentist. I still do crown and bridge all the time, or fillings. And whenever I had issues, I always joke is I've prepped crowns on 2 and 15 all the time, and I've never had a patient come back several months later with an open contact. Like how when I cemented the tooth, there was a nice tight contact. They come back later, and there's some type of occlusal interference that the patient has that I just didn't see, and they've clenched or grind and moved that tooth back to open up that contact. I had some type of interference that I missed. So I always say the maxillary molar seems to move a little bit easier than my mandibular molars. So that's why I put mandibular molars first and maxillary molars second. And just remember the direction that maxillary molars like to go is being pushed distally. That's an easy movement for those teeth to move. I'll then go ahead and think of the premolars second. And then the weak teeth, I think this is pretty self-explanatory, is the maxillary incisors followed by the mandibular incisors. So we want to put these forces, if we have to, if we have to deal with forces somehow, let's put them on the maxillary canines and the mandibular canines and the mandibular molars if we have to. My choice would be not to put them on the maxillary incisors, and definitely I don't want to put them on the mandibular incisors because those force vectors are going to create teeth, and typically in the maxillary incisors and mandibular incisors, we can't really hide them in the right plane. So if we're going to put forces on the mandibular incisors, typically it's going to be a labialization, which then can create a decrease in overjet. So I bring this slide back up, and I want you to think of where the forces are, where that connection point is, because we know where the connection point is, that's where there's going to be more forces put on those particular teeth. So when I see the midline push-pull, we're getting a labialization of the mandibular anterior teeth and a lingualization of the maxillary anterior teeth. That is a movement that is not ideal. And I think there's other appliances that we can choose to hopefully mitigate side effects of the tooth movement in this direction. Okay. So weakest teeth, also putting a lot of force on those teeth and in the direction that we don't want to decrease overjet. And once these teeth hit, then we can start creating some posterior open bites. Now, bilateral push appliances. Where do we see the force vectors here? And are they in a line where we can maybe typically absorb some of the pressure from these forces? Herp style appliance, if you look, it's putting maxillary molars and distalizing them. That force that I just talked about, that maxillary molars often do and often move and open up contacts, is it's putting the force on there, and then it's putting the force on the mandibular canines and the mandibular anterior region, and again, labializing them a little bit. So while it's better, it's putting force on a little bit stronger teeth, you could technically still get some side effects maybe fairly commonly by putting on and opening contacts and getting some tilting of the maxillary molars and potentially, if it's too far forward, getting some forces on the mandibular anterior teeth. Now, the world where I like to live in a lot is kind of C and D. Again, C and D, where we have this bilateral interlocking or fastened, or we'll call it dorsal, the different types of name brands for you. And C, we're putting forces kind of in that maxillary molar region and in the mandibular mandibular molar region, premolar canine region. So I'm happy with putting forces on those particular teeth. Maybe if you're too far distal, you could still be putting a lot of force on the maxillary posterior teeth. Hopefully that interlocking device or connection is a little bit more anterior to put more pressure on those canines. So I like using this type of appliance if it's needed and called for. And then the bilateral pull. Where are we putting forces on those teeth, and what teeth are we putting them on? With the bilateral pull type of appliances, if you can get the connection in the right point, you can get it into that maxillary canine region, which is great. And then you're also putting forces on the mandibular molar region, and you're moving those teeth potentially towards the adjacent teeth, the mandibular anterior teeth, and getting pushed because you're pulling here. So therefore you're getting a push to create tighter contacts in that particular area. And I'm going to highlight real quick this design, because there's this oblique connection that a lot of bilateral pull appliances have. And then there's a lot of a different appliance where you get more of a connection vertical, and then the band goes horizontal. And I think there's some benefit to that as well. And I'll talk to you about that towards the end of the presentation. So hopefully we've kind of accomplished lesson objective 1 is just look at appliance design and how do you think it could potentially affect some of these teeth. So this was a great paper. I think it was released a couple years ago, if not more now. I see it all the time, and I see it quoted where it talks about all of the potential side effects that mandibular advancement devices or oral appliance therapy can do when you're treating patients for sleep disorder breathing or obstructive sleep apnea. And they created this great chart from this paper and broke it down into temporal mandibular joint related pain, intraoral tissue related side effects, occlusal changes, damages to teeth and restoration, and appliance issues, breakage, allergies, gagging. The purpose of tonight's lecture is to focus a little bit about temporal mandibular joint side effects and how we can mitigate those potentially with appliance choices and appliance design, and then focus in on occlusal changes. I think that's the big one, altered occlusal contacts or bite change. And I feel like all of these under the occlusal changes category can be interrelated and kind of called one or potentially the other. And how, when we go into the details of appliance design, how when you look at certain appliances, they look at all of these things and try to mitigate or minimize potential occlusal changes. And we're talking about bite changes, incisor changes, decreased overjet overbite, and then interproximal gaps as well. So all of that's interrelated, and I'll hopefully touch on each of those as we go through. And they broke this paper into 19 side effects. A lot of them were watchful waiting. Watch them, see if the muscle soreness calms down, see if there's TMJ discomfort, see if that goes away. There's a look at appliance modification, and then also appliance modification. Do we change or move them forward or backwards, faster, slower? And then the appliance. Do we need to alter the appliance? Do we need to change out the appliance? But whenever I see a side effect, I also see follow-up appointments and problem appointments. And how do we mitigate or fix those problems appointments to get this patient wearing the device? And if we get the patient wearing the device, then sleeping better. And then overall feeling better systemically. But I also, from a dental practice manager or practice management side of things, is when I see problem appointments, I potentially see wasted time or lost revenue and or unhappy patients. So the goal is always to mitigate or minimize follow-up appointments, as well as any remakes or redos or things of that nature. So this is where we're going to start focusing on the Panthera appliance, the DSAD and the X3, or the Panthera DSAD/Classic and the X3, and what they call, or Panthera calls, biomatch. Panthera has taken a super deep dive into all of those potential bite changes or side effects and try to minimize that as much as possible, and going into very minute detail, and not overlooking really anything when it comes to these appliances. So you're going to see this term called biomatch. And when you fill out a prescription form, they give you the option of using what's called biomatch and allowing their algorithms, their experience, their history with making these appliances to the best of their ability to mitigate side effects. You can customize the appliance if you want to, and I'll go through that, how we customize it, why we would customize it at the end of this lecture. But I'm going to go through their thought process and what they've created with this biomatch. So the first thing that they've done is they've created nylon. And they didn't create nylon. They use nylon for their appliances. And I love nylon as a material because it can be super strong when we need it to be. And if we need it to flex, then we can create the appliance and create bands to allow it to flex in certain circumstances. And I think there's actually a benefit to an appliance that can bend in a certain way at a certain point in time. I'll talk about that coming up. It's also super thin. And for sleep apneic patients, tongue space or oral volume is absolutely key and crucial. So if we can make this appliance 1-2 millimeters thick on the tongue side, or potentially even eliminate some of the nylon on the tongue side, that's awesome and what I'm looking for. And then the thinner, the better. The thinner, typically the more comfortable, and the patient appreciates that. And then if the patient appreciates it, they tolerate it and they wear it more often. And then when we talk about improves chair time profitability, I hinted at when we minimize the side effects, we minimize the time patients come back. I also want an appliance that fits the first time the right way. So I don't have to send back for any remakes. And I kind of look back at why I think digital dentistry has helped the sleep world so much. And if you're not using digital dentistry, I think everyone that has is going to tell you to jump in the bandwagon. It's going back to dental school. Yes, I remember having to mount all of these models on a semi-adjustable Hano articulator or a SAM articulator. And we did it when a patient was in maximum intercuspation, centric occlusion, centric relation. But we were able to create a fairly stable bite and then mount it with the plaster. And I'm sure there was some type of discrepancy when we did that. Now imagine doing that in a protrusive bite, edge to edge, 2, 4, 3, 4, 5 millimeters apart. And these two appliances that you're trying to mount are now floating in the air. I guarantee you there's going to be more discrepancy in every single dimension when you try to mount these models. When you send them to the lab, they're doing the best they can, but there's going to be some slight discrepancies. If there's some slight discrepancies, don't be surprised if the final product that you get back, there's going to be some discrepancies and some adjustments you have to make. When we send it digital, we have that model, everything is done digitally, and there is no human error involved with mounting this case. It is all done digitally. So I know Panthera begs and pleads you, because I know their remake is significantly lower when you send them a digital impression versus traditional analog. And if you want less remakes and more profitability and predictability in your practice, think about going digital. So let's talk about when we go ahead and we can choose to customize things, or we can use what's called optimized values or biomatch. And I'm going to talk about how they've come up with creating what they think Panthera thinks is the ideal appliance to mitigate as many side effects and as many tooth movements as possible. So the first thing they're going to ask you is if you select biomatch, they're going to ask you if there's any teeth that are fragile. And if there are any teeth that are fragile, they will not have the appliance touch that tooth. When we go back to that very, very first slide, or that thought process that I initially had getting into the sleep world, is I wanted to splint everything and hold it all together. And even though that first person where that connection is putting a lot of force against that wall or against that tooth, or the appliance where that connection point is putting more force there, there's still force on that last patient. And if that last tooth or that person that's pushing, if there's still force being spread across, and it happens to get spread across a very fragile tooth, it doesn't take a lot of force to start to see some movement or some side effects. So tell them if there's a particular area, if it's a bridge, a cantilever bridge, is it periodontally involved teeth? Is it splinted mandibular anterior teeth? Tell them where that is, and they will relieve it to make this appliance mitigate or have any effect on those particular teeth. The next thing that they do is when they make this appliance is they need to mitigate occlusal changes or interproximal spaces in the molars, premolars, anteriors, anywhere you're talking about. And when you start to engage or put a metal clasp or put acrylic or put nylon in between these contact points, it acts like a wedge. The same wedge that we put in when we're doing a class 2 composite or a class 2 amalgam, and we put our matrix bands on and we wedge it. You can see the effect of just a small little wedge and how it impacts the adjacent teeth with floss. It can open up contacts or change contacts just by putting that wedge in there. So they want to mitigate as much as they possibly can, putting any material in the contact point. Not the Panthera nylon doesn't have any metal, but they can still 3D print potentially nylon in that contact point if they don't have enough retention by other portions of the teeth. So because of their CAD-CAM or CAD technology, CAD is always design. I always get CAM-M for manufacturing. The CAD design is they can wax out or create virtual wax out so the appliance doesn't invade that interproximal space. And if it doesn't invade that interproximal space, they eliminate the wedging effect. So they look at, can we get enough retention in areas of like the undercut or the gingival undercuts on most teeth? They're going to put the undercuts there. If they have to and can't get enough retention, then they will go into the interproximal and leverage it that way. But their first choice and their first desire is to create an appliance that just hits the buccal or the lingual so it doesn't have any contacts start to open. So that's the first thing they do in their design process. Now, when we talk about overbite and overjet changes, and I first want to talk about the research here. As you can see, over time, over 5, 10, 15, 20 years, there is a slight decrease in the overbite, and there's also a slight decrease in the overjet as well. This is a very old paper. I think it came out in like 2006. I mean, it followed these people for that particular long time. These were all monoblock type of appliances, so not appliances that we're typically using currently. But I want to take a quicker look at it. Is that statistically significant? Is that change of millimeters over a certain amount of time each year, is it statistically significant? That 0.2, that 0.3, that 0.4 each year? Maybe. It looks like it's statistically significant, but is it clinically significant? Okay. Is it going to have an impact on the patient? That's the first thing I want you to just think about and let that soak in. The other thing when we talk about overbite and overjet is when we measure overbite and overjet, we're just looking at the mandibular anterior position. So is that just a tooth movement of the mandibular anterior teeth? Is it the whole block of the maxilla moving back and the whole mandible moving forward? is it a change in the muscles and the posture? So when I hear the term overbite and overjet, there's a lot more that goes into it except just potentially maxillary anteriors, mandibular anteriors having an impact. And I would love to see if in the future, when we start going down with research papers, if they can look into that from a skeletal change, from a muscle posture change. Is it a tooth change? Did it go from a class 2 to a class 1? Or all of that, just not using a generic term of overbite and overjet. So the other thing is this a type of appliance? Is a very classic appliance. And I'll show you the paradigm shift that I think is occurring, is that not all appliances could potentially change overbite and overjet. And also, which appliances could change overjet and overbite more depending on where they're putting those forces on the teeth. That kind of leads me to the next slide here. And I always love this paper because they have CPAP as well. So I always know that, like, when we talk about our medical colleagues and they're like, well, you might have a bite change, I can show them this paper too and say, hey, when you're wearing a CPAP, you can also get a bite change potentially. And there's going to be some overjet and overbite changes as well. And then you look at the different type of appliances. We have the dorsal fin type of appliance, and then we have the tap type of appliance. And if you go back to those slides, is where are these appliances? Where's that connection point, and where are they putting more force on? Or where are they putting the force, and what teeth are they on? Are they putting it on more fragile teeth, like a tap appliance, the maxillary and mandibular anterior teeth? Or is it a dorsal fin that could be putting more forces on the lateral aspect where we have some stronger teeth? We have the canines, the premolars, and the molars. And if there's still a change here, is it skeletal? Is it muscle? Is it just the front teeth? What's going on here? And is it, so we need to take a deeper dive at some of these old papers. And I think that's where a lot of the research is changing, is looking at individual teeth or individual types of teeth and where we have movement. So that goes into kind of some newer papers that are starting to come out. The orthoapnea, I would consider interlocking type of appliance. We have the herp style, which I would call some type of push appliance. And then this somnobent with this research paper, from my understanding, is the dorsal fin appliance. And you're going to look at where all these appliances are putting forces on it. And you again do see this maxillary arch getting kind of pushed backwards, especially the maxillary anterior teeth. And you get the mandibular anterior teeth in all three of these cases getting pushed forward. So we're starting to see a decrease in overjet. And when these teeth get to a point where they hit each other, that's where we can start to see overjet, definitely overjet, overbite changes, but also potentially posterior open bites if these teeth collide prematurely. So let's talk about the Panthera X3 appliance here. It's their dorsal interlocking appliance. And I don't know if you're going to be able to see my mouse on the screen here, but this is the piece of the appliance that you can remove and thicken up right before on the maxillary arch. That's where you can thicken it up. It comes with different pieces that fit in there, and you can titrate the patient more forward and push then the mandible forward. It's been a great appliance to have in my tool belt. And when we start talking about these push appliances, or what I will then also consider a dorsal interlocking appliances, we're not surprised by these force vectors. And I have appliances on my desk here. I hope you can kind of see what we're looking at and why we could potentially still get an overjet change, a lingualization of the upper anteriors, and then a labialization of the mandibular anteriors. And remember, when we talked about forces here, it's what vector or what direction they're going. When I'm showing you the occlusal surface, so this is the integular, this is the occlusal, and when we push down, you can see we get potentially a widening of the appliance. And then when we widen it in the lateral direction in the posterior segment, potentially these forces in the anterior create a lingualization of the maxillary anterior teeth. And if we talked about forces, if you have one force, you're going to have an equal and opposite force. If we have the mandibular arch and we're pushing this down, we could then potentially get an arch. I'm going to pop this off, where we bring this forward and then create a lingualization of the mandibular anterior teeth. And that's what this research paper is showing. For the push devices, for the interlocking devices, this is where we get some labialization of the mandibular anterior teeth, lingualization, I'm going to swallow my tongue here, labialization of the maxillary anterior teeth, and a lingualization of the mandibular anterior teeth. Now, how do we mitigate this? You're going to see in a couple slides why they've designed appliances with bands in a certain way to minimize these movements, okay? Now, I talked about the equal and opposite force, so they're moving in opposite directions. Now we look at more research papers that are looking at forces on individual teeth. We talked already about this central connector, this tap type of appliance. And when we put forces on these front teeth, we're going to get lingualization of the mandibular anterior teeth, potentially labialization of the mandibular anterior teeth. But we're also putting a tremendous amount of force on those particular teeth, more force on these teeth when the connecting point is in the anterior. This second one, this lateral connector on the left here, that is a herp style appliance. So putting some pressure on the mandibular canine region and then a distalizing force on the posterior segment. But if you look at the research here, when you get a lateral connection, you start to get a decrease in the overall force. When we talk again about side effects, we're trying to decrease the amount of forces on everything. So the smaller the forces, the better. Again, when we look at a lateral connector, in this particular case, it's a somnavent, it's a dorsal fin. When we get forces on the lateral aspect of these appliances, the forces start to go away. And then the hybrid connector, in this particular case, it's a somnavent avant. When they have that connective piece right in the maxillary anterior teeth, you can see again when we start putting more forces on in the anterior segment rather than the lateral segments, there's a lot more forces. So start to think of maybe we can design these appliances by putting a lot more force on the lateral, diminishes the total amount of force, and if we diminish forces, we could potentially decrease side effects as well. Here's another paper that kind of did the same thing, but it actually looked at individual teeth and where did they move. When we talked about that in the first initial slide, you're going to see that labialization of the mandibular anterior teeth with a central connector or tap appliance. You also see a little bit of lingualization here as well to decrease that overjet. Now look at the lateral connector here, or a herp style appliance. Where is the most force? I kind of look at Doppler radar. Whenever we look at a weather report, we always know that we want to see either nothing or light green. We never want to see like the dark, heavy red. You can see it's putting a distalizing force on those maxillary molars, an area that I've been known to see pop up just anecdotally in my office. We see a lateral connector. We see not as much red, maybe a little bit on those maxillary molars. And then when you do that hybrid connector where we're putting that connective piece right in the maxillary anterior, you see how much pressure and what are they doing? It's bringing those maxillary anterior teeth back. So what do we have here? We have all this research showing, let's put forces on stronger teeth. Let's try to get the connection on the lateral aspect of the jaw or of the lateral aspect of these teeth to decrease all of these side effects. So I'm going to jump over now to the classic device, or the Panthera DSAD, which is what I would call a pull device. So similar features, all made out of nylon, a super strong material. The great thing about this is whatever appliance I've made, I always start to see some wear and tear, some breakdown. I've never seen a catastrophic breakdown with a Panthera classic device. I've had to change out a band very rarely, but that's all I have to do, and I can still get that patient back with their appliance that particular day. But we'll talk about the research that shows that while it may be small, we can potentially limit TMJ pain as well. Now, this is where I think we have a big paradigm shift here, okay? And this is the one that took me a while to sit with. So if it doesn't make sense tonight, while you're listening to this webinar, go get an appliance and start playing with some of these forces and how this potentially impacts things and what teeth are going to move where. Because what I'm going to show you is this DSAD or classic could actually have the opposite effect of decreasing the overjet. This appliance, if it does have a side effect, may increase the overjet. And I would rather have that issue than a decreased overjet, overbite, the teeth starting to collide, and then we have some open bites. So again, I'm showing you this from the occlusal standpoint, and when we think we're going to start pulling this appliance back, and what happens is that what the diagram shows here is we get essentially the teeth starting to move inward, in towards the midline, but that movement inward can potentially cause this appliance on the lingual to push forward and actually labialize or protrude the maxillary anterior teeth forward, increasing overjets. And when we talk about forces, equal and opposite forces, so if I have mandibular, the lower part of this mandibular advancement device, this DSAD or classic, what we could potentially have is this is getting pulled up. There is a lateralization. That's why it's a lot designed a lot thicker with the material, so that force doesn't get transferred to those teeth. And you also see the band here. The band on the labial side of the maxillary anterior teeth is removed because that could potentially cause a force coming back. Now we're trying to mitigate that, and there's certain reasons they design these appliances. So the research is starting to show that, I know it's ingrained in our heads that overjet decreases with mandibular advancement devices. With bilateral pull devices, it actually may be the opposite. More research and multiple research papers need to come out to show this, but that's where it's headed. And I think that's a much better alternative than decreased overjet and overbite. And when does that decrease in overjet become clinically important? Or I should say clinically significant. So I also described about this and hinted at this earlier in this oblique versus oblique titration, this diagonal titration versus a titration system that is more parallel with the occlusal plane. And we're going way back, not physics in high school or in undergrad. We're talking geometry here and the lovely Pythagorean theorem. How the Pythagorean theorem works is the hypotenuse with a right triangle is the hypotenuse. The diagonal is always the longest. From a biomechanical or engineering perspective or physics perspective, the longer that hypotenuse is, the more force is transferred along that line or that vector. So when we have appliances that have more of an oblique or diagonal connector, there's potential to have more force. Now, we're not talking about a lot of force. We're talking about 13 newtons versus 9 newtons. Potentially not a huge change in force vectors here. But when we're mitigating side effects, we want the forces to be as low as humanly possible. And this subtle design change where we have this arm that goes vertical and then the titration band goes horizontal, decreases the force slightly. If it decreases the force, it then puts less force on the joints and also less force on the teeth themselves. And this is another research paper that kind of backs that out. Again, not significant in, like, not massive differences in newtons when we talk about force vectors. But again, the oblique style, or in this particular case, we're talking about Herbst versus the classic, there's a decrease of forces from 41 newtons to 37 newtons. Again, not earth-shattering, but any microscopic gain is going to make this appliance potentially better and the side effects lower. And the other thing that I like about the pull type of appliances is it promotes a lip seal or mouth closed approach. And I know all of us in the sleep world are trying to get these patients back in an ideal circumstance, lip seal, nasal breathing. And if we have a device that helps force the lips shut versus a Herbst, which has a downward vector and could potentially create a little bit of an opening there, the better. So all these little nuances add up to an appliance that hopefully mitigates these side effects. And I know we talked about the differences, the X3, or all the dorsal fins, these kind of more push appliances have that decrease in overjet, and where the traction devices, the pull devices, could potentially increase the overjet. And like I said, I would rather have an increase in overjet. It's going to be less noticeable by the patient. So that movement is in red for the traction. The blue is the push device. Now, why are certain devices and the bands built a certain way? And this is where, when you play with these devices, the upper band for a classic, if you had a band on the lingual and you bend this appliance with the forces directed on it, that band on the lingual could exacerbate or increase or put pressure on those maxillary anterior teeth. Okay, that's why they've gotten rid of it in their design. And we say the equal and opposite reaction, if we're talking about the X3, which decreases overjet, they relieve, in most of their biomatch cases, they're going to relieve or remove the band on the buccal, because that buccal piece could push the teeth back, retrocline them, and decrease that overjet. So there's subtle nuances to these appliances, and all of these nuances, there's a reason, there's a method to their madness to decrease tooth movement. And when we have decreased tooth movement, we're trying to decrease the side effects and increase the patient wearing this device. And if they're wearing it more without the side effects, they're seeing me less often. So again, with this, when we're talking about pull appliances, as the rods get shorter, we're titrating them more forward. And then we have different bands and different plateaus, and we're going to get into that here. If you need to use this and customize this in a particular way, Panthera gives you that opportunity. When you go ahead and on their prescription form, you click customize with plateau or band, I say it's going to open Pandora's box. You're going to see all of these different options on there. And they're there for a reason, in case the patient needs them for certain reasons. So we have bands. You can design just buccal, full, half lingual, half buccal, full, just lingual, and then three-quarter, like half. There's so many variables here, and then so many variables on the lower as well, in case you need them. And then you also have plateaus. Where do these devices hit each other? And I will talk to you real quickly before we start running out of time, why we choose certain type of appliances. So their most common one is this lateral on full. They think it minimizes stress on the TMJ, some anterior in the opening for increased airflow if the patient is a little bit of a mouth breather. So that's usually their go-to. They can also design the bands going back to that biomatch philosophy. When we talk about full on full, the reason they need to do a full on full is it's short teeth, and they need to get as much surface area and retention as possible. So they're going to distribute the load amongst all of the teeth, but also increase the retention as well. Now, anterior on full, I'm going to skip that to the next slide, but on the reason why I use an anterior full, and it's typically on my bruxers who've broken night guards or broken appliances before, or just wear the heck out of their teeth. Lateral on lateral is typically for those people that cannot breathe in their nose. They have massive deviated septum. They have a clogged up nasal airway, and we need to create a little opening in the appliance to allow them to mouth breathe. Now, this isn't ideal, but this is if those patients cannot breathe through their nose, why we do lateral on lateral. Now, let's jump back over to anterior and full and why we do it. The analogy that I always heard is when you get two bottle caps between your finger and you push down, you can generate a lot more force in comparison to putting two marbles between your finger and trying to balance those two marbles and put those forces together. So when we do anterior on full, what we're trying to do is mitigate as the forces that these patients are doing when they clench or grind their teeth. If we only get their anteriors to touch, they can't generate as much force as when we get full on full and full occlusal contacts. They can generate more force back up to their 100 maximum value. So if you have these big clenchers, these big grinders that have broken everything you've ever put in their mouth, think of creating this anterior on full. So now, when do I use what? Indications for an X3 versus the classic, or I'll call it the DSAD, digital sleep apnea device, is I like to live in the world of the DSAD. I like one piece of type of appliance, just my personal preference. But there are particular cases like posterior crossbites, or when, just think of those where the connectors are, and if there's no teeth in that area, we can't use that appliance. So if there's certain circumstances where there's no teeth there, maybe the maxillary canines and the mandibular molars are gone, I'm gonna have to switch to something like an X3 that I'm gonna have to lean towards, or if I need more retention potentially, the X3, because of the force vectors, there's no potential pulling off the appliance from the opposite arch, may be a better solution for me. So these are kind of the things that I look at. So talking about, hopefully we accomplished the learning objectives that we set out for today. We talked about appliance design, how each appliance design potentially has an impact on teeth, how different appliances that are on the market will affect different teeth. We talked about materials, nylon versus metal clasps, how that could potentially create some side effects with openings between the teeth. We talked about the strength of nylon material, and then all of the things that Panthera does when they're designing these appliances and how they're trying to, in the hierarchy of forces, minimize the forces on the teeth if we have to, more of a lateral approach. If we do have to put forces, put them on stronger teeth, the canines, the molars. And then if we have to make some type of decision, how do we create that hierarchy and how do we live with something? And then I think the paradigm shift, which there's going to be more research coming out this if not in the next weeks, months, years, is potentially this bilateral pull device could actually increase overjet, and that's something that I could definitely live with. I don't think patients will notice that, and it's not clinically significant, or maybe it is clinically significant, you have some nitpicky patients, but I think these patients won't notice that as much as the decrease in overjet when all of a sudden we have some major bite changes. So I am wrapped up with what I had prepared for this evening. I will open it up to questions. I think Dr. Carstensen has some already.
Well, thank you, Dr. Martin. That was an amazing study. I love physics, and so I was rapt as you were going through all that. And I'm really gratified to see that there are some actual studies that show these forces, because I've been around a long time and I've heard a long time about the decreases and increases in overjet and overbite, like you talked about, and Dr. Markland's paper from 2006, which now is forever ago, talked about those things. And for you to bring that forward for us into 2016, 20, and 21 is really fascinating and shows.
And we'll see what 23, 24, and 25 have in store for us.
Yeah, but it shows how they're paying close attention to these oral appliances and the companies and the materials that are staying up with the science. I think are going to bode well for our contribution to overall health as we go forward. So you brought forward some really great points here. I do have a question for you, a couple questions. The nylon material, that's not something you and I learned about in dental school. And so as a dentist looks at that, relatively unknown material, can you talk a little bit more about the nylon and how is it different from acrylic? What does a dentist need to know? Adjustments, additions, staining, cleaning, all those. Can you just contrast materials a little bit?
So Panthera, it makes it out of a nylon material. There are several other nylon materials on the market. There's a herb style appliance. I'm always a little, whenever I get, I've been burned with PFM crowns, and when you start getting materials matching with each other, I'm always concerned about breakage. And how materials merge together well and how they get married. And my PFMs, it's always the porcelain breaking off from the metal. I want a material as much as I can to be all one material would be my goal. The other thing about the nylon in general is it's typically 3D printed. So they can do some pretty cool stuff with it on how they design it. And it's also extremely strong, extremely strong. I've had patients accidentally drop appliances or night guards off the kitchen counter and they break or chip or things of that nature. I've yet to really see anyone break this in a catastrophic way where I can't change it or adjust it and get this back into the patient's mouth when they come in. The one thing is you do have to use a different type of acrylic burr. So it's I don't have it memorized. I just know it's a Brasseler. It's a thinner burr. It has a yellow stripe on it. Any Panthera rep will know it. But that is something slightly different. I always joke about when I see that lovely staining that they've been soaked in mustard. Again, going back to that overjet, I don't know how clinically significant that is because I've never really seen any patient soak it in mustard and see that it's yellow compared to an acrylic device. I think that's dentists making an issue truly out of a non-issue. And I also think when we talk about all of these devices, there's never a clean or pristine device that comes back after they've been wearing it. So there always is going to be some dirt or grime on any of the appliances that come out. And then it's super strong, and you only need 1 millimeter of thickness for the material to be strong enough. So that means a total of 2 millimeters of opening when we make these devices. And then you can keep it slim and trim on the lingual to increase that oral volume. So I think there's a lot of benefits that nylon brings to the market.
Yeah, I want to point out something that I know because Panthera was a gracious host of me as DSP editor a couple of years ago to their manufacturing facility in Canada. And yes, it falls in the general category of 3D printing, but these are laser sintered additive manufacturing. And have you been to the headquarters?
I have not. I've been invited, as my schedule hasn't allowed it yet, so I'm looking forward to it.
Take advantage of their wonderful hosts, and the facility is incredible because these machines take that nylon material and they use lasers to build it up from zero. So it's not printed out like you think of the Best Buy printer that's squirts a material out of a hose. This is built up with lasers, and so the advantage I see with the Panthera nylon is that it's so much easier to be super polished and stay that way. And I find it difficult to stain. It's so, I guess if we do soak it in mustard, we could stain it, but like you said, who does that?
Dijon, yellow, what's your choice?
So I think in real life, anybody can stain anything. It's individual biofilm that does that, but I don't see that as a major problem. What do you recommend to your patients to clean their appliances with, by the way, Jonathan?
I have like the Oro Fresh that I've typically used that I've had success with. That's what it's down at like in my daughter's drawer right now for cleaning her retainers. So that's typically my go-to.
We like Stain Away Plus. We think that does a great job on the nylon materials. Yeah. So another question is, when you were talking a little bit about the action of the anchorage on the upper and the pull forward on the lower, did you mention the distal wrap, and does that make a big difference for you? And how do you deal with that?
So I always prefer a distal wrap if possible, because it's like going the extra step to get something to wrap around the distalmost molars on each side and just try to hold those teeth together as much as we can. Now, teeth are going to move when we talk. Like if you're thinking you're going to get these appliances and they're never going to move, you probably haven't done enough appliances yet. Teeth are going to move, unfortunately, but it's doing everything in our capability, understanding the engineering, understanding the biomechanics, understanding the physical, the force vectors, to try to minimize that, wrapping distals, putting the forces on the strong teeth, or all the things that kind of go into that. It's just not slapping this device that yanks the mandible forward.
Right. And one of the other things I like dentists to be aware of is, yeah, we're dentists. We're very concerned about tooth contact, about flossing contacts, about, labialization of teeth. But don't forget that the reason why we're doing these appliances is because there's an overwhelming medical problem that we're trying to solve. And that's where dentists need to step back a bit and make sure that they keep their eye on that medical outcome.
It's going back to that hierarchy of what's the worst side effect. I know dentists get really uncomfortable when we talk about this, is they get so ingrained into their sphere of influence, which is the teeth. Let's put some more thought process into this and think hypertension, heart attacks, strokes, all that stuff that is a definite side effect of having untreated sleep apnea way outweighs the risk of potentially a tooth change. Now, it's important. We need to put some thought into mitigating those side effects, but let's just rank those real quick in our minds.
Yeah, I talk about oxygen to the brain. I think that's really more important than having a contact that opens up between molars. But
I joke that like breathing is so underappreciated. Like we need it every 10 or 15 seconds or we can't survive.
Right. But using a high quality device for opening the airway and keeping the oxygen flowing is going to be able to meet both of our comfort zones, right?
Yeah.
Yeah. So say a little bit more about the fit and finish and delivery appointments for Panthera versus some of the other devices.
So I hinted at my lecture, we do everything digital. I teach at CDOCS. That's the whole continuing education course at CDOCS is everything digital, using prime scans to create very accurate models. So I think having digital goes into it. But once you're able to go digital, they have their CAD software at Panthera. But typically, I'm not even in the room for deliveries. They go in, they fit. They hardly ever need any adjustments. Chair time is valuable. So the less chair time, the more productive and profitable I can be. So having that in my background, that I've delivered hundreds of these devices, and the predictability of it, the polish, patients tolerate it well. And that's another reason why we do it digital. I know Panthera has been able to disclose some information to me where their remake is significantly less when you send them something digital.
Yeah, digital is certainly going to be the future of that. I have a contrast for you when you mention the polish is, in my position, I get sent new appliances all the time, and I love to try new appliances. And I just got a new nylon appliance not too long ago, and the contrast between the fit and the finish of my DSAD and the one that I was sent is night and day.
Yeah.
So the way that they come in from the manufacturer there, and the fact that they're all made in one facility gets Panthera's ability to control their quality levels way up there.
Yeah.
And so it's just a wonderful device for our team to deal with as well. Yeah, they smile when one of those is on a delivery sheet.
Yeah, they know it's going to be easy.
Yeah. Well, that's all the questions we have come in so far. Is there anything else that you want to say that to wrap things up, Jonathan?
I think I've said everything that I was planning on saying. Thank you for giving me the opportunity to kind of share what I think is a very predictable appliance that gives my patients great results. So just sharing my story.
Yeah, thank you for the time you spent preparing this, and we really appreciate here at MedMark Media Panthera's support over the years, and thank you for Panthera for supporting this webinar. But I really appreciate, Dr. Ford, that you brought forth, a lot more than just excellent appliance. I think we both agree on that. But you got us some science here, and you got us some good things that dentists can think about in order to be able to provide good medicine for their patients and partner well with our CPAP and physician colleagues as part of the solution for these breathing problems that's around us every day. And so as dentists out there, I hope that you're inspired to go out and look for those patients to treat, to do something about it, and realize that the appliance portion of what you can provide your patients for care doesn't have to be the hard part. So thank you for watching our webinar tonight. I hope you enjoyed Dental Sleep Practice Magazine, and have a good evening.